This video continues Chapter 24 of OEC 6, looking at abdominal and pelvic trauma, and it specifically focuses on the assessment of patients with injuries to these regions. When we look at patient assessment, nothing will change in terms of our general assessment process. However, identifying exactly what may have been injured does require our knowledge of anatomy. We always want to ensure that the scene is safe, and we want to initiate standard precautions before beginning. Then we'll address life threats, looking for external bleeding and the ABCDs. A patient history is important because if you find out during the last oral intake, that the patient has consumed alcohol or drugs, understand that the symptoms of this trauma or the pain could be masked by that. When you ask about a patient's pain, use the OPQRST mnemonic device and have the patient point with one finger where it hurts the most. This will help you determine, using your knowledge of anatomy, which quadrant and what organs may have been impacted during the injury. Later, pain may become more diffuse rather than localized if intestinal contents have leaked into the peritoneal cavity, causing peritonitis. Severe internal bleeding is not always obvious, but may become obvious later with rigidity in the abdomen. Part of our OPQRST mnemonic device also is the idea of radiation, or in the case of spleen or liver injury, referral. We may get pain that irritates the underside of the diaphragm and therefore radiates or is referred to the upper left shoulder. This is a finding known as care sign. Left shoulder pain in the absence of an actual shoulder injury could indicate a ruptured spleen. Consequently, right shoulder pain may indicate a lacerated liver. Now, our head-to-toe assessment, again, the physical exam will look for these particular signs consistent with abdominal or pelvic injury. We're looking for pain or tenderness or visible wounds. Abdominal distension or rigidity upon palpation could indicate internal bleeding, and that would be accompanied by our vital signs findings pointing towards the presence of shock. So we look at the abdomen for abdominal distension, enlarging over time, becoming more distended, could indicate bleeding inside the abdomen. A large band of bruising across the lower abdomen can occur in a motor vehicle accident. We call this seat belt sign. It may take several hours to appear, but we get these contusions right at that site. We consider also in our secondary assessment these other possibilities using our DCAT bottles algorithm. We're going to be looking for discoloration, the idea of contusions or bruising. When it comes to palpation, we palpate the lower rib cage, remembering the liver and the spleen are somewhat encased there as well. Palpate all four quadrants of the abdomen, and then assess the integrity of the pelvis moving lower by placing your palms right on the iliac crest and applying inward pressure. If we find bone crepitus or pain, we may have the possibility of a pelvic fracture. Palpate the pubic bones gently. Maintain patient dignity during this. To assess the front of the pelvis, we can use the patient's hand on the pubic bone and then push on the patient's hand. Only one rescuer should examine for a pelvic fracture. If you examine more than once, you may move towards life-threatening bleeding by disturbing a blood clot that has started to form. When we talk about treatment, it's also important to remember, don't log roll the patient with a suspected pelvic fracture. Opt for a lift to move them onto a spine board. Genital injuries are going to be very painful and may be associated with a pelvic fracture, and it's important again to maintain patient dignity. One OEC technician with a second in attendance is very critical during this, and include a parent or guardian if dealing with a minor in this case. If indicated, you can look for bleeding for this external injury, soft tissue injury, as required. Always consider the possibility of shock because these regions of the body are highly vascular and several liters of blood can accumulate, especially in the pelvis, resulting in hypovolemic shock. If you see falling systolic blood pressure and a decreasing level of responsiveness alongside possibly tachycardia, consider the possibility of shock. Any injury in these two cavities has the potential for serious blood loss, especially left upper quadrant injuries, the location of the spleen. Serial sets of vitals will give you a good clue to this, watching for trends in the vital signs. And consider again abdominal distension or pain or elevated pulse rate and decreasing blood pressure as key signs for shock setting in on this patient. We might provide high flow oxygen and transfer to definitive care.